Thank you, everyone, tonight for joining the minimally invasive surgery talk here regarding minimally invasive bunion surgery on behalf of Dr. Sharona Williams, who is our foot and ankle orthopedic specialist here at Wilmington Health. We're very excited to have her share this tonight on behalf of our med school seminar series. I'll go ahead and let you, Dr. Williams, introduce yourself tonight.
Good evening. Thank you so much for joining us to discuss bunions. Tonight, I'd like to talk about bunions and how we classically treat them in the past, and about a more innovative way that's really taken off with minimally invasive surgery. So I'm new to the community here at Wilmington Health. I joined Wilmington Health in September and just excited to be a part of the orthopedic team and provide service for this community.
Dr. Williams, I do want to say, I think I've always been really impressed too with the fact that not only are you a fellowship trained orthopedic surgeon, but you're also an accomplished athlete. So you bring a lot of understanding for our community that I'm sure they're all going to really appreciate.
It is exciting to be both a physician and both a patient, because it definitely helps with empathy and really, understanding what the patient's going through. So excited to present, excited to be here. I'm just going to tell you a little bit about myself. Originally from Philadelphia. Upset the Eagles didn't win the Super Bowl, but that's okay. And I spent the last 17 years in Atlanta, Georgia, doing orthopedic foot and ankle surgery, and happy to be here on the coast. So.
Awesome. We'll let you go ahead and get on into it.
Okay, so tonight, again, we're going to talk about hallux valgus and standard ways to treat it, but we're going to have a focus on minimally invasive surgery as an option for treating a bunion. Next slide. So bunions, also known as hallux valgus, are more common in women. There are genetic and other risk factors that make bunions more likely. So, as I was saying before, when I see a patient, I ask them, "So, where'd you get your bunion from?" And they usually say Aunt so and so or Grandma so and so, because there's 70% chance that they got it from a family member. Other intrinsic factors that increase the likelihood of a bunion is increased DMAA, which is a distal metatarsal articular angle, which we will talk about in the next couple slides. Ligamentous laxity, where you have a little bit lax ligaments, and we'll talk about some of the mechanics of that medial capsule and how it stretches out in a bunion. Convex metatarsal head, that's just a morphology that lends towards the deformity. Second toe amputation, if you take the second toe away, you take away the guardrail or the buttress of the bunion, of the hallux. And so it tends to migrate over to the third toe, which produces a pretty severe deformity. And again, having a pes planus, or also known as a flat foot, will allow for the hind foot pronation to put additional pressures on the big toe. Next slide. So extrinsic factors. So it occurs almost exclusively in societies that wear shoes, and particularly in America, where we have high fashion shoes. It's fairly common. Patients usually present with tenderness immediately. A lot of times you have to look out for second toe pathology. So that big toe is pretty bossy, pretty powerful, and will push that second toe up and over, sometimes up and under. So you'll get you can get some forefoot pain. So you have to look for that. Next slide. So a little bit about, just go through normal anatomy. I don't have my pointer, but if you look at the first metatarsal, so that's the first metatarsal, and then you go second, third, fourth, and fifth. Typically, they are parallel. And when the first metatarsal goes into varus, or going to the right, it's called primus varus. And when the hallux, or the proximal phalanx goes to the left, it's into valgus. So there's normal anatomy, including the adductor hallucis, and the abductor hallucis that create balance. And when they get out of balance, and you get contractures of the capsule or stretching out of the capsule, you get a bunion. Primarily, the adductor hallucis tendon is a deforming force, and you can see, if you look to the left of the hallux, where that sesamoid, the sesamoid is the little, I call them the eyeballs of the foot. These, are you pointing at that? Yeah, thank you. So the adductor inserts into the lateral sesamoid into the proximal phalanx, and that becomes the primary, on the other side, of, there you go, it's a primary deforming force of the bunion. And then now if you go to the right side of that, of the big toe, yep, the abductor starts to rotate plantarly and into valgus, taking that toe into pronation. So rotating the toe. So basically it's a complex deformity, and sometimes people oversimplify thinking it's just a bump, but there are a lot of moving pieces and imbalance that needs to be thought about in when you go to address a bunion. Next slide. So when you come in, it's important that we get weight-bearing films, usually AP, lateral. We get oblique, and sesamoid views can be helpful as well. There are lots of angles that we look at. The main angle or primary angle is the intermetatarsal angle, and that's on your left side. And if you bisect that first metatarsal, the line is drawn, and if you bisect that second metatarsal, that line is drawn, and when you get the angle, that's the IM angle. Normal is less than 9. And if you look at an X-ray and you see that first, second, and third metatarsal, typically they're parallel, and then the first and sometimes the fifth, so a bunion or a bunionette, they veer off and diverge. And so that's the angle that you're looking at. Now, there's also the hallux valgus angle, which if you bisect that proximal phalanx, then intersects with the previous line drawn on that first metatarsal, and that's the hallux valgus angle. And normal is less than 15. The other thing we think about or need to consider is that DMAA that I spoke about previously, and that's just the articular cap. And so if it's leaning to the side, you now have what we call a congruent bunion. And that's a different animal. So that's typically present in adolescent or juvenile bunions, and they need to be addressed a different way or they will recur. We're not talking about juvenile bunions tonight. So we mentioned it, but we're not really addressing those or discussing those. Other things we need to think about is arthritis in that great toe. I think that the arthritis, it will exist in majority of patients that we see, but it may be subclinical, and that'll be important. But if you have so much arthritis, then a bunion procedure will make you a straight toe that is still painful, which will not make the patient very happy. Okay. So Of course, when patients come in, first thing we do is we try conservative treatment. Well, what can we do besides surgery? Can we avoid surgery? So shoe wear modifications critical. There are wider toe box shoes, and standardly we used to go get shoes made, but now they're actually off the shelf stylish shoes that have a wider toe box, like the Ultra running shoes. So they're reasonable, and people wear them. My runners wear them. Other things that you can do if you have shoes that you want to wear is get a ball and ring shoe stretcher. And it's pictured there where you can, that helps with the bunion, that helps with hammer toes, that helps with calluses or corns to shape the shoe so that you're not getting the irritation. And there's bracing and splinting. And there are about 1 million things you can get on Amazon that will not correct your bunion, but can support it and take some pressure off and potentially make shoes a little bit more comfortable. Next slide. So surgical treatment. Well, of course, if symptoms persist despite all the recommendations for conservative care, then we think about surgery. I want to be clear that surgery should not be performed for cosmetic reasons. So cosmesis is not an indication. And studies have shown that if you do surgery for cosmesis, the results go down drastically. So it's not an indication. It should be pain, or it should be like difficulty with shoe wear because of the bunion, but not just because of the looks of the toe. So surgically, we can address it with soft tissue procedures, which usually that's not done in isolation. So it's a combination of soft tissue with an osteotomy. There are different types of osteotomies. There's the distal osteotomy. Distal means further down the metatarsal, like say just proximal to the eyeballs, so right proximal to the sesamoid. So go right there, right? So that's going to be your distal metatarsal osteotomy, and that's usually an osteotomy that will be chosen if you have a mild to moderate bunion deformity. Proximal osteotomies, you can go back where you were, Desiree, a little proximal right there. Yep. So that's at the metaphyseal flare, and that's for the moderate to severe bunions, because you need a little bit more power in that correction to straighten up that IM angle. And then finally, if you have instability, or if it's a recurrent bunion, if you had previous surgery, some folks will go to the TMT joint. So that joint proximally, go over to the big toe right there. Yep, right there. So that's our first TMT joint, and that's a lapidus. And lapidus procedure's been around for a long time, but recently the Lapiplasty has been popularized by a company named Treace. So it's very popular, and people come in asking for that particular procedure. But each bunion procedure is selected for the patient specific, depending on how they present and what needs to be addressed. Of course, if you have arthritis in the big toe, then a fusion procedure at the big toe joint, yes, is indicated. Again, if you have a straight foot, good looking foot, but you have a severe arthritis or symptomatic from arthritis, you're not going to be very happy with that. So regardless of what surgery you choose, the goals are, and now you can point to reestablishing that MTP joint congruency. So go to that bit right over, that's your sesame right there. Yep. So you want to see that's incongruent. We want to restore that, correcting that hallux valgus angle, rotating or reestablishing the sesamoids. So those sesamoids are rotated laterally. And so we want to make sure we put that metatarsal sitting back over those sesamoids. And then finally, we want to correct the IM angle. So we want to close that IM angle down. That's right. And create, remember I talked about the first metatarsal not being parallel. We want to make it parallel so that it lines up over those sesamoids. Next slide. So again, and I'm not going to belabor this, but there are over 100 surgical procedures described for the correction of hallux valgus. So it's a pretty common procedure, and there's no one way to do it. But generally, as I said before, proximal osteotomy is for the bigger deformity, and then distal ones for the smaller deformity, and then fusion for instability. Next slide, please. So again, it's a summation of the algorithm. Here it's pictured a great toe arthrodesis. Patient had arthritis, so a fusion was indicated. The picture, oh, I'm sorry, it's not pictured. I had a Lapidus procedure there, but it's pretty big incision, and that was more for what I wanted to show you. But next slide. So complications with bunion surgery, recurrence. So there's 16% recurrence rate, and then multiple reasons for recurrence, but sometimes it's failure to recognize that DMAA, non-compliance, inadequate correction, not proper rotation, lining those sesamoids and metatarsal back. So many reasons. Avascular necrosis, that's been reported with lateral release along with a distal metatarsal osteotomy. Dorsal malunion, that's a fancy word, but basically you correct, you do osteotomy and it heals in a wrong position, allowing for transfer metatarsalgia, where the lesser toes take more weight than the big toe because the big toe is sitting up. Hallux varus, that occurs when the toe keeps drifting. So you take it out of that valgus position and you put it in somewhat a neutral position, and it keeps going over into varus. And that happens when you overcorrect that IM angle or do too much of a release. Cock up toe deformity, that's when you injure that flexor, the FHL tendon on the bottom, and that toe just sticks up because there's no restraint or resistance from the extensor tendon on the top. Second, MT, transfer metatarsalgia. So the big thing with bunion correction, and all bunion corrections, unless you're doing an opening wedge bunion correction, is you're gonna get some shortening of that first metatarsal. So you don't want to shorten it too much, or now the second toe is taking the load of the big toe and you can get lesser toe of forefoot pain. Neuropraxia, obviously the dorsal medial cutaneous nerves in that region, so it can get injured. And stiffness and scarring. So you saw some of the pictures previously. They're pretty big scars, and you can get trouble healing the wound. You can get adhesions and stiffness. So if you have a nice straight toe but it doesn't move, that doesn't help you get into the shoes that people are trying to get into. Next slide. So, now we can really broach the subject of what we want to talk about, minimally invasive surgery. So, and in recent years, it's been, minimally invasive surgery has just exploded. So there's standard techniques, and they've taken small incisions, carefully planned incisions, use fluoroscopy and burrs to do osteotomies and corrections. So you have immediate weight bearing, faster recovery, less pain, less stiffness, less wound healing complications, decrease infection rates, and at the same time, through the same procedure, you can address mild, moderate, or severe bunions, which is excellent. Next slide. Basically restating everything I just said. Next slide. So evolution of MIS. So MIS has been described in as early as 1970s. And there were several pitfalls, and partially because there was no fixation. So there was osteotomy and just positioning, and You would get non-unions, malunions, which means it just wasn't healing. There was fraught with complications. And then people start using fixation, so K-wire fixation, but we're still getting pin site issues, avascular necrosis. And so in the US, that halted percutaneous surgery and development, but it still continued to bloom outside of the US. Next slide. So as the evolution continued, the results improved and it became reproducible. So we're currently on the third generation of minimally invasive surgery, which includes internal fixation and allows for increased stability with early weight bearing. So next slide. So there are numerous published studies that have demonstrated excellent results with minimally invasive bunion surgery, with less pain, fast recovery, less complications that were equal or better than the open procedures. So I'm going to explain how this progressed so quickly and how this exploded. Next slide. So types of burrs. So there are burrs specific for minimally invasive surgery. They're designed for osteotomies, and they're also designed to cut or morselize bone. Next slide. And here's just an example. So there's literally burr specific design depending on what cut you're trying to make and what procedure you're trying to do. So there's hammer toe burrs, there's flat foot burrs. So on the right side, it says calcaneal slide, chylectomy, that's for arthritis and debriding it. And then down in the left corner is for bunion. So all these procedures, which we're not going to discuss specifically, come with pretty big incisions and have their own set of complications. So doing it through a small incision is really changing the landscape of foot and ankle. Next slide. So, and this is an example of some of the implants and how they were designed for percutaneous surgery. So they've got special designs, there's self-drilling tapping, there's constant pitch, they're chamfered, they're recessed, and so they sit positioned well and buried just below the bone to not be prominent. Next slide. So other things that helped us continue to improve and optimize minimally invasive surgery was finding the optimal RPMs, because one of the complications with MIS was heat generation. We worried about burning the soft tissues and the nerves. So finding that optimal speed, which you see 4,000 to 6,000, but you can go as high as 10,000 depending on bone quality. So you've got some people have pretty hard bone, so you might have to go a little bit higher, but you're balancing power with heat. High torque, low speed. And at the same time, you see the picture there, the irrigation. So continuous irrigation, anytime the burr is running, your copious irrigation to make sure you don't get a heat issue. Next slide. So how do we do it? Well, foot is off the edge of the bed. The patient's in Trendelenburg, and this is because we're not using a tourniquet. So that just lessens some of the blood flow. We want the blood flow, so that cools the burr as well. So all these things to try to minimize complications. Next slide. So initially, again, using lots of fluoroscopy to make sure we're in the right position. You go right at the metaphyseal flare, make a small millimeter to 2 millimeter incision and get your burr, angle it about 20 degrees and start to burr. If you'll go to the next slide. So here we spoke about shortening. So this is how we address not shortening that metatarsal by just angling that burr towards the metatarsal neck of the second metatarsal. It's about 20 degrees distally. And you see in that red line how that will lengthen. When you shift that metatarsal head over, it will lengthen versus shorten or keeping it neutral. We don't want shortening. Thou shalt not shorten. Next slide. So the other key is looking some of the reduction tools and other devices that are made to be able to operate through millimeter incisions. So this is a nice reduction wire that's sharp but rigid, and then but it's flexible, so that I can push that fragment over. And then at the same time, there's a rotation that's happening to get that metatarsal head to sit over those sesamoids. So you've got to supinate that fragment, the toe, and would go distal to that, go down, go up a little bit, I'm sorry, for that towards the joint. There you go, yep. So you're taking that toe, so I'm even further than that, that's not pictured, and I'm taking that toe into varus and supinating it while I hold that reduction. Next slide. While you hold that reduction, this is just an example that if you don't have all these specialized instruments in your tray, there are trays that's just in a standard hospital on a podiatry tray or foot and ankle hand and foot tray that you could utilize to do the same thing. Next slide. So once you get that reduction, then you have to put the K wires in at the base of the first metatarsal, which is not shown. It's not shown in that slide. It will probably be in the next slide. But as you're reducing it, you will have to get 2 cortices, and the wires are parallel to get the maximum bite and purchase in that metatarsal head, so that you control for that rotation and get stability. Next slide. So this is showing you that example of how now you can see more proximal. So go down to exactly, and then go south. Right there, right at that base is where you want to enter, and then about 8 millimeters distal to that, you start your next wire to get it parallel. Once you get it in the position you need to, you check, so you have a flat foot plate to make sure that that we've corrected that pronation of the toe, and that the foot looks good in a weight bearing. So we simulate weight bearing in the operating room. And then once we like it, then next slide. Then you drill, and some people don't necessarily drill, depends on the quality of the bone. So if the bone is hard, then you'll drill, but otherwise these screws are pretty sharp and self-drilling, self-tapping, so you don't necessarily need to drill. Next slide. So and then we finish up with an Aiken osteotomy. So with the distal metatarsal osteotomy, you also will do an Aiken osteotomy, and that's classically either an transverse osteotomy or an oblique osteotomy. It's up to the individual surgeon. But with that burr, you take out a wedge of bone and basically green stick it and take the toe into varus, and then secure it with you see the wire crossing that osteotomy right in the middle of those pictures. Right, exactly. And then you measure again. Don't typically drill, just put this bone here usually doesn't require to drill, and you put the screw across it. And some surgeons will do a lateral release. I don't find it necessary. I'm sure that in certain situations it is necessary. But it's interesting because classically in open bunion surgery, I did a lateral release every single time, and it's just not required in this minimally invasive setting. Next slide. Next slide. So the post-op protocol. So pretty much weight bearing is tolerated in a short leg boot after the regional anesthesia wears off. So it's outpatient surgery. Patients get a popliteal block, so that leg is numb, and that could be anywhere from 24, 48 to 72 hours of not feeling the leg, depending on how you metabolize that medicine. And soon as it is awake enough, you can weight bear in that boot. You're in the boot for about 6 weeks. At 6 weeks, you go into a stiff sole shoe versus a rocker bottom. So that Hoka tennis shoe would work. We let them get on a bike at 4 weeks in a regular shoe, but then they put their boot on for walking. And typically they can start going back to their activities, whatever the activities are, between 12 and 16 weeks. But by 4 to 6 months, they're back to normal. Next slide. So this is an example of a case here in Wilmington that we did recently. This is, if you go to the left, all the way to the left, that's her pre-op films. You see the second, third, and fourth metatarsals are parallel, and you see that her first metatarsal and her fifth metatarsal angle out. So we call it a splay foot. So that's classic genetics there. She had, and then you see her clinically what she looked like in that second picture. She had difficulty with shoe wear. She had pain. So we thought she'd be a great candidate. So this is her foot, probably about a week or so post-op. And then on the right is her intraoperative film. And she was ecstatic about her foot, never had pain, never took a pain pill. She did take a little Motrin and Tylenol, but that was about it. So next slide. Questions?
Thank you, Dr. Williams. I appreciate it.
Thank
Looking
you,
forward
Jeff.
to, yeah,
I'll
looking forward to
I'll
seeing
see
you next week.
Tuesday. That's
That's
right.
with that skinny boot.
That skinny bee.
Hey, Dr. Williams, if the bunion is worse, why is it easier to fix if the bunion's worse?
Yeah, that's interesting, right?
Yes.
Because it's such a wide angle. You've got so much room for that shift, and the angle that you're firing it. So when the wires, it's just easy to get the wires and get those two cornices because it's such a drastic shift over.
Right.
And so it just moves over a little bit easier. The wires, the angle, it's easier to get the fixation and to correct it. So it's interesting.
Yes, it is. Awesome. Well, great presentation. Enjoyed it.
Oh,
Thank you
thanks
for
for showing up. Appreciate you.
Yeah, for sure. All
I'll
right,
show
guys
you
have a good
tomorrow in
night.
clinic.
All right. Bye-bye.
Okay.
And I guess some questions I usually will have with things like this is, what does that recovery look like? I know that you covered that a little bit there in the post-op, of course, but what do patients say when they come out of the surgery room and they're back with their families and waiting? What do you guys tell them at that time when they're going home? How do they look out for their foot other than the boot and things like that? What is some advice to them?
So I typically, I try to slow them down a little bit because there's not a lot of pain with it. And yes, they're weight bearing, but I always say, listen, you had surgery. Your weight bearing is tolerant in that boot. So anytime you're walking, you're in that boot. But don't go crazy because you can be in your house and you can just be on your foot all day. So just remember, you did have surgery, even though they're small incisions. You still had trauma to your foot because anytime we intervene, it's trauma. It's just you're going to swell. Swelling's normal. But they just don't have the pain and they feel really good. So I just tell them, try to take it easy for 2 weeks. Give me 2 weeks, even though they're small incisions, let's let those little small incisions heal. And then after that, I really let them go. I mean, let them walk in that, and they're just walking in that boot.
That's awesome. I have a question here. How long does this procedure typically take?
So and there's a high learning curve with these. So, and it depends. So it's interesting with this, the worse the bunion, so the more severe the deformity, the easier it is to fix, which doesn't make a whole lot of sense, but it does. So the smaller the deformity, the longer it may take to do it. So I think when you get going and get running, you can do this probably in 40 minutes. So, but there's a lot of strategic where we put the fluoro, where your scrub tech's gonna be, you know, instrumentation, and just kind of, it's more of a getting the theater and getting people used to, it's a new way of surgery. So.
Awesome. Are there any other questions? As I said, feel free to use the chat or feel free to unmute yourself.
Hey, I had a quick question. Did you guys discuss contraindications or patient requirements for this procedure?
We did not. So same thing. So it's based, you know, this is not for everyone. So as I was saying, with even before MIS existed, with every bunion, it's unique, and you've got to look at hypermobility and any other issues that that specific bunion requires. So it's something that I would tell the patient to inquire about, but they may not be a candidate for MIS.
Thank you.
Mm-hmm.
Thank you, Eric. All right. Well, for a few more moments. Okay, well, awesome. Thank you all tonight for joining Dr. Sharona Williams' med school seminar. We really appreciate the engagement tonight. I feel like we all learned a great deal about bunions, things that I never knew. That's pretty interesting, actually. So awesome.